my name is Chelsey Barrett. I'm a graduate nursing student at West Texas A&M University. Today I'm going to be performing a head-to-toe assessment on a 32-year-old male who comes into established care. Prior to this, we have already obtained his past medical history, any surgical history, allergies, medications, or pertinent family history. We have also obtained his height and weight, which reveals a normal BMI within normal range. We have also obtained his vital signs, which were all within normal limits. And we have also tested cranial nerve number 2, the optic nerve with the Snellen eye chart, and he displayed 20/20 bilaterally with correction. I'm going to wash my hands, and now we're going to begin this assessment. So first, I'm just inspecting the skin, making note of any lesions, moles, or nevi that are present, looking at the hair distribution, looking to see if there's any thinning of the hair, and there does not appear to be. I'm also looking at the patient, just generally inspecting him. Patient appears to be relaxed. Patient does not appear to have any body odors, and patient is dressed appropriately at this time. Also, patient's color is normal for his ethnicity. So now I'm going to move on to the head. Here I'm just inspecting the head for any lacerations or nodules, and I don't see any there. Also just looking at the hair, making sure that there's no thinning of the hair, there's no lice or dandruff present, and there is not. So now I'm going to palpate the scalp. Here again, just looking to see if there's any bony prominences or tenderness felt there. Do you have any tenderness? No. Okay, perfect. So while I'm here, I'm just going to go ahead and test for bilateral temporal pulses. They should be 2+ as his are. I'm also going to palpate for the frontal and maxillary sinuses. Any tenderness with that? Okay, and now I'm going to go ahead and test for cranial nerve number 5, the trigeminal nerve. So I'm going to use this cotton tip applicator, and if you could let me know if you feel sharp or soft.
Soft. Sharp. Soft. Sharp.
Good. So patient responds appropriately to that. So now I'm going to go ahead and test for the temporal mandibular joint. I'm going to assess that. So if you can open your mouth for me. Good. I should be able to fit about 2 to 3 fingers back behind his jaw as I am. And if you'll close your mouth for me and open again, and then just move your jaw from side to side. Perfect. So here I was just looking to see if there was any difficulty with movement, if there was any popping or clicking sounds, and his did not appear to have any. So now I'm just going to make note of the symmetry of his face. So looking at his eyes, and they're bilateral and symmetrical, and his ears are symmetrical, and his nose and mouth are midline. So now we're going to move on to the eyes. First, I'm just going to assess the conjunctiva, making sure it's nice, pink, and moist, as his is. And then looking at the sclera, making sure that it is clear and white, as his is. If there was any yellowing there, then that might indicate jaundice, which is seen in liver failure. And I did not know any of these. So now I'm just going to go ahead and test for direct and consensual pupillary response. If you could just look forward for me, sir. I'm going to flash this light into your eye, looking at direct and consensual. And moving over here, direct and consensual. And on inspection, I was looking at his eyebrows and eyelashes, and the hair distribution looked great there. There was no thinning present. Whenever I tested for direct and consensual, the patient responded appropriately. His eyes dilated, and they were between 3 to 4 millimeters, which is within the normal range of dilation. So now I'm going to go ahead and test for accommodation. So if I could just have you, sir, look at my pen light, and then look at that back wall. Pen light, back wall. Perfect. Patient responds appropriately. So now I'm going to test for cranial nerves number 3, 4, and 6, ocular motor, trochlear, and abducens with the 6 fields of with the cranial nerves, with the 6 fields of gaze. Sorry. So if I could just have you follow my pen light for me. Perfect. So here I was just looking to see if there was any nystagmus or jerking eye movements. The patient did not appear to have any of those. So now I'm just going to take a look at the optic disc, making note of the red reflex. So I'm just going to put my forehead on your, I'm going to put my hand on your forehead here and just look into your eye for the red reflex. Good, the optic disc looks nice and sharp. I'm going to come over here and look again. Good, perfect. So now that we're done with the eyes, I'm going to go ahead and move on to the ears. So first I'm just going to do a general inspection of the ears, making sure there's no lesions. I don't notice anything there, so now I'm just going to palpate the auricles of the ear. Do you feel any tenderness there?
No.
I don't feel any lesions or nodules present. And then back behind here, do you feel any tenderness?
No.
Okay, perfect. So now I'm going to go ahead and take a look at the tympanic membrane. So for an adult, I'm just going to pull up and back on the pinna. And here I'm just going to be identifying landmarks of the tympanic membrane, making note of any redness or overproduction or discharge, swelling of the tympanic membrane that could indicate infection. Good. Tympanic membrane is nice and pearly gray on that side, so I'm going to come over here and look. Up and back. Good. The tympanic membrane is pearly and gray there as well. So now I'm going to go ahead and test for cranial nerve number 8, the acoustic test. So sir, I'm going to step back behind you. I'm going to whisper a number to you, and if you could just repeat it back to me.
55.
Good.
66.
Good. So now we're going to do a few more tests. So now I'm just going to do the Weber's test. This is checking for lateralization of hearing throughout both ears. So if you could just let me know if you hear this evenly throughout both of your ears.
Yes.
Okay, perfect. And now we're going to do the rhyme test. This is testing for air-to-bone conduction. And it should be 2 to 1. And let me know when you stop hearing the vibrations.
Okay.
Oh. Perfect. So now I'm going to go on to the nose. Here I'm just looking at his nose, making sure again that it's midline, making sure there's no deviated septum, and there does not appear to be. So now I'm going to check for patency. So I'm going to occlude one nostril, and if you'll take a deep breath in for me, and out. Good, and occluding this one in. Any difficulty with that? Okay, perfect. So now I'm going to test cranial nerve number 1, the olfactory nerve. So I'm going to have you close your eyes for me, sir, and just let me know what you smell.
Alcohol. Alcohol.
Okay, perfect. So now I'm just going to take a look inside the nares. Here I'm just looking to see if I know any redness, overproduction of discharge, tenderness within the patient, or any polyps. Just tilt your head back for me. Good. Perfect. And everything looks great there. So now I'm going to move on to the mouth. Here I'm just doing a general inspection of the lips, making sure that the lips are pink and moist, that there's no lesions present, and that the lips have good color to them, and they do. So now I'm going to look inside your mouth. So if you could just open your mouth for me. Here I'm just looking at the oral mucosa, making sure that it's pink and moist. Hard and soft palates are intact. If you could lift your tongue up for me. Here just looking at the vascularity of the tongue, making sure that there's no ulcers or lesions present in the mouth, and there doesn't appear to be. So now we're going to do some cranial nerve tests. I'm going to test cranial nerve number 9, the glossopharyngeal, which is the gag reflex. So if you'll just open your mouth for me. Okay, perfect. So patient responds appropriately to that. So now I'm going to test for cranial nerve number 10, the vagus nerve. Alrighty, sir, if I could just have you say "ah" for me.
Ah.
Good, and the uvula rises midline, and that looks great. So now I'm just going to go ahead and assess for cranial nerve number 12, the hypoglossopharyngeal. So if I could just have you stick your tongue out for me, sir, and then if you could just move it side to side for me. Perfect. Here I'm just making note of any lesions or ulcerations, there doesn't appear to be. So now I'm going to finish up with some cranial nerve tests. I'm going to do cranial nerve number 7, the facial nerve. So here I'm just going to go ahead and have you smile for me and then puff out your cheeks. Good, that looks perfect. So now I'm going to do tests for the cranial nerve number 11, the spinal accessory. So if you could just shrug your shoulders for me. So push down. Good. That looks great. So now we're going to move on to the neck. So first, again, I'm just inspecting the neck, making sure that the trachea is nice and midline and that there is no deviation and there doesn't appear to be that would cause any difficulty with respiratory issues. So that looks great. So now I'm just going to palpate the thyroid. I'm going to step back behind the patient. I'm going to have you tilt your head forward for me, and then if you could swallow. Good. Here I would make note of any enlargement, any tenderness, or any nodes that were felt, and I did not feel any within this patient. Did you have any tenderness? Okay, perfect. So now I'm here, I'm going to assess for lymph nodes. I'm going to be assessing the preauricular, postauricular, submandibular, submental, cervical, postcervical, and supraclavicular. And I'm going to just go ahead and have you put your arms out like this for me, and I'm going to go ahead and test the axillary lymph nodes at this time. Good. And those lymph nodes were mobile. If they had been fixed, then I would suspect that they could be tumor related. However, he didn't have any tenderness, there wasn't any enlargement of that, and they were mobile. So now we're going to move on to range of motion within the neck. So I'm just going to have you, if you could just tilt your head to your shoulder for me. Good, and to the opposite side. And then if you could go up with your neck and then down. Good. Now I'm going to be testing for muscle strength. So I'm going to place my hand up here against his face. And if you could just look at that wall for me over there. Good. Perfect. And then on this side, if you could look at that wall for me. Perfect. Okay, so patient has good range of motion and muscle strength in the neck. So now I'm just going to palpate for the carotid. I'm going to test one at a time, making sure not to block off that blood flow. It should be 2+ of normal as his are. Now I'm just going to listen to the carotid, listening for any swishing sounds or bruise. Take a deep breath in for me, and then out. Perfect. No swishing sounds or bruise noted. So now that we're finished up with the neck, I'm going to go ahead and just have you turn around for me, and I'm going to assess the posterior chest. Yeah, perfect. Just like that. Okay, so here I'm just looking at his posterior chest, making sure he's not having any difficulty with breathing, and he doesn't appear to be. Also looking at his chest expansion. So I'm going to place my hands here. If you could take a nice deep breath in for me and out. Okay, here I'm just looking to make sure that my thumbs rise evenly and symmetrical as they do. So that looks great. So now while I'm here, I'm going to go ahead and test for costovertebral angle tenderness, or CVA tenderness. So if you could just let me know if you feel any tenderness, sir. Any tenderness there? Okay, perfect. If the patient had some tenderness, that could indicate a urinary tract or a kidney infection. So now I'm going to assess for tactile phrenitis. So if I could just have you say 99 for me.
99, 99, 99, 99.
Increased tactile phrenitis could indicate inflammation, whereas decreased tactile phrenitis indicates air or fluid would be in the lungs, and this patient does not appear to have those at this time. So now I'm just going to percuss along. I would expect to find resonant lung sounds, but if I heard any point of dullness, I could expect that there was fluid or infection present in the lung. And if I heard hyperresonance, then that would indicate that the lung was overinflated, and that would be more in COPD or asthma. So that looks great. So now I'm going to test for diaphragmatic excursion. So if you could take a deep breath in for me and hold it. Here, just making note of that point of dullness. And then if you could take a deep breath in for me and let it out. Again, making note of that area of dullness, and that's our diaphragmatic excursion. Now I'm just going to also take all lung sounds. I'm going to be listening for any adventitious lung sounds that would indicate bronchi, wheezing, or crackles. Just take some normal deep breaths for me, okay? That's good. Okay, and breath sounds were clear. So now I'm going to go ahead and test for bronchophony and egophony. Alrighty, sir, so first I'm testing for bronchophony. If you could say 99 for me.
99, 99, 99, 99.
And now say E.
E, 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 E.
Okay, and both of those were negative, but if they had been present, that could indicate pneumonia within the patient. So now I'm going to have you turn around for me, sir, and I'm going to go ahead and inspect the anterior chest. I'm going to pull down on your gown, if that's okay. Perfect, so here I'm just making note of his chest. He doesn't seem to have any difficulty with breathing. Looking at the AP diameter, he doesn't appear to have a barrel chest. He's not tripoding, so he's not having any difficulty with breathing at this time. So now what I'm going to do is I'm just going to test for thrills and heaves. I'm going to use the palms of my hand and the pads of my fingers. Good. And now what I'm going to do is I'm going to palpate for the point of maximal intensity, the PMI. So I'm just going to come right here, and I can feel his, but if he had an enlarged heart, I might have to move more laterally. But I can feel it, and it feels good. So now I'm just going to percuss the lung sounds on the anterior chest, again looking for just resonant lung sounds. And that sounds great. So now I'm just going to take a listen to his lung sounds. Just regular deep breaths for me. While I'm here, I'm just going to listen for lateral breath sounds. Good. And that sounds great. So now I'm going to go ahead and listen for heart sounds. I should hear a strong S1 and S2. So first I'm going to start in the second intercostal space, right of the sternal border at the aortic valve. Then the second intercostal space, right of the sternal border, and left of the sternal border in the pulmonic valve. Third intercostal space, left of the sternal border. Fourth intercostal space, left of the sternal border in the tricuspid valve. And then the fifth intercostal space at the apex of the heart or the mitral valve. And I heard a good strong S1 and S2. No extra heart sounds were heard. So now I'm just going to go ahead and listen for any murmurs. So I'm going to start at the base of the heart. I'm going to take the bell of my stethoscope. I'm just going to start at the apex of the heart. the base of the heart, and work my way down to the apex. And no murmurs were noted. So now I'm just going to go ahead and have the patient, just if you could lean back for me, sir. We're just going to go all the way back here. And here we're going to assess for jugular venous pressure. I have the head of the bed at 30 degrees. And here I'm just going to place my centimeter ruler at the sternal angle. And then I'm going to take an index card and I'm going to place it at the highest place of the meniscus. And his is about 3.2, which falls within the normal range between 3 and 4. And if for some reason he had a higher number than 4, that could indicate fluid overload that's seen in heart failure. Alrighty, so now I'm just going to pull this gown down a little bit and we're going to move on to your abdomen. I'm just going to lie you flat. Sorry. Good. Okay. Perfect. So first now I'm just kind of inspecting the abdomen, just making sure that there's no bruising of the umbilicus or around the umbilicus, that there's no pulsations or paralysis issues, and I don't see any at this time. So now I'm just going to go ahead and listen to all four quadrants. Patient has normal active bowel sounds. If he had hyperactive bowel sounds, that would be seen in increased intestinal activity that's seen in diarrhea. If he had hypoactive bowel sounds, that would be seen in intestinal obstruction, like in a bowel obstruction, with decreased intestinal activity. Okay, so now that I've done that, I'm going to go ahead and move on to listening for the aorta and femoral arteries. Good. So now I'm just going to percuss the abdomen. And those sounded good. Those were like tympanic percussion sounds that I heard. If I heard any dullness, then that could indicate that there was an organ or a full bladder. So now I'm going to go ahead and percuss the liver. I'm going to go midline of the umbilicus and move my way up to the point of dullness. And making note of that line. Then I'm going to start at the nipple midline and I'm going to percuss my way down to the point of dullness here. Making note. So it's about 5 to 6 centimeters, and the normal liver span is between 6 and 12, so his appears to be. So now I'm going to go ahead and percuss for the splenic dullness. And I did hear that. So now I'm going to go ahead and do light palpation. Here I'm just seeing if I feel any masses, looking at the patient to see if he has any tenderness. He does not appear to. So now I'm going to go ahead and move on to deep palpation. It should be about 5 centimeters deep. I'm going to stick my left hand back behind his back. And I'm just going to have you take a nice deep breath in and out and just relax. And here I'm just percussing for that liver. Palpating for that liver, sorry. And I do feel it is nice and soft. It's not hard or firm, which would indicate liver failure. So now I'm going to go ahead and palpate for the spleen. So again, I'm going to put my left hand back behind here and with my right go at 5 centimeters deep. I don't feel the spleen, but that's normal. And while I'm here, I'm going to just deep palpate for the kidneys. I'm going to move on to this side and palpate for this kidney. Good. So that all looks good there. So now I'm just going to have you lift your foot up for me. Like this. Perfect. And if you could just lift your leg, I'm sorry. And then dorsiflex your foot up. Good. Any difficulty with that? Okay. Move on to this side. Lift this leg up for me in the air, and then dorsiflex your foot up. Like pull. Yeah, perfect. Any difficulty with that? Here I'm just checking to see if there's any herniated discs in the back, and there doesn't appear to be. So now I'm going to check for range of motion in the hips. So I'm going to go ahead and put this down up, sorry. And I'm going to have you relax this hip for me. Just kind of let me hold it in my hand. Good, so here I'm going to do flexion of the hip, internal rotation of the hip, external rotation of the hip, extension of the hip, abduction of the hip, and adduction of the hip. Good, that looks great. So now I'm going to move on to this side. Again, I'm going to have you just relax that hip for me. Good. So showing flexion of the hip, internal rotation of the hip, external rotation of the hip, extension of the hip, and then abduction, and adduction. And while I'm on this side, I'm going to go ahead and check for range of motion of the knee. So I'm going to have you bend your knee for me. Good. Showing flexion of the knee, and then internally rotate, externally rotate, and extend. Good. Onto this side. This knee, flexing that knee. Good. Internally rotate, externally rotate, and extend. So now I'm going to test the ankles for their muscle range of motion. So if you could pull up on my hands, perfect. Testing for dorsiflexion, if you could push down on my hands, good. Testing for plantar flexion, patient appears to have good range of motion. And so now I'm going to go ahead and have the patients sit at the edge of the bed for me now. And we're going to move on to our upper extremities. So first I'm just going to have you place your arms out like this for me. Good. This is adduction, and then going across. That's adduction. Sorry, this was abduction, and this is adduction. And then if you could go back behind your head, and this is external rotation. Good. Back behind your back, internal rotation. Great. So that looks good. So now I'm going to go ahead and test range of motion in the elbows or muscle strength. So I'm going to have you put your arms up like this for me, and then try to pull up against my hands. Good. And then just extend. Perfect. So good range of motion and muscle strength in the elbows. So now I'm just going to go ahead and take a look at the wrist. So I'm going to have you place your hands out like this for me. Looking at the fingers and knuckles, everything looks great there. So now I'm just going to have you pronate and supinate your hands. So just go like this for me. Perfect. And then if you could do it fast. Perfect. So that is just testing for cerebral function, and patient does so appropriately. So now I'm going to go ahead and do test your hand grips. So I'm going to have you grab onto my fingers as tightly as you can. Good. Patient responds appropriately there, has got good muscle strength. So now we're going to do some neurosensory checks. So I'm going to have you just place your hand out with your palm up and close your eyes. I'm going to draw a number in there, and if you could tell me what it is.
3.
Perfect. Now I'm going to place an object in your hand, so just keep your hand out. Let me know what you feel.
Paperclip.
Good. So this was testing stereognosis, and patient responds appropriately to those tests. Also, again, testing for cerebellar function. So now we're going to do some point-to-point tests. So if I could have you put your palms down out like this for me. Perfect. Now close your eyes. And what I'm going to do is I'm going to touch a finger, and if you could touch your nose with which finger I touch. Perfect. Patient responds appropriately there. So now we're going to go on to the point-to-point. If I could have you rub your heels up against your knee and down, up your shin, from your knee to your ankle. And then on the opposite side. Perfect. That's great. So now while I'm here, I'm just making note of the hair distribution, making sure there's no varicose veins present in this patient, and there doesn't appear to be. So now I'm going to just check pulses. We've already checked the temporal pulses and the carotid. So now I'm going to test the brachial and radial, and those were all 2+ and normal. And now I'm going to go to the popliteal, 2+ and normal, popliteal, 2+ and normal, tibialis pedis, 2+ and normal, in the dorsalis pedis, 2+ in normal. And while I'm down here, I'm going to test for proprioception. So if you could just look straight ahead for me, I'm going to either pull up or down on your toe, and if you could tell me which way I'm doing that.
Up, down, up, down.
Perfect. So now I'm going to go ahead and move on to reflexes. So I'm going to have you put your arms out like this for me, just kind of like a scarecrow. Here I'm going to be at the elbow. If you could just relax that for me, and I'm going to be testing the tricep reflex. Good. And on this side. Perfect. And now if you'll put your hands out like this for me. Good. Now I'm testing for brachioradialis. And the patellar. And the Achilles. Good. Patient has good reflexes. So now we're just going to go ahead and I'm going to have you stand up for me. Here we're just going to do a test for ataxia. So you'll just stand right there. Good. And if you'll close your eyes for me, here I'm going to assess his balance. That looks good, and that's the Romberg test. So now I'm just going to have you touch your toes for me. Here I'm just looking at the spine, making note that there's no curvature that would indicate scoliosis, that it's nice and midline. Also, again, just looking at the SI joints. If you could come up a little bit more for me. Good. Looking at that spine, making sure there's no curvature there, that would indicate scoliosis. So that looks great. If you'll stand up for me now. Now we're going to do some tandem walking. So if I could have you go from heel to toe, just right back to that, or right here. Forward. Perfect. And then if you'll turn around and if you could just stand on your heels, good. And then on your toes. Perfect. So patient has good muscle strength. So now I'm just going to have you sit down for me, and I'm going to continue on with some more of the exam that would be more specific. So if this patient was a female, I would have her place her arms at her side, and then I would also to inspect the breast, and I would also have her place her arm back behind her head. Here I'm just looking to make sure that the breasts are nice and symmetrical, that there are no masses, that there's no nodules, any visible rashes or redness, that there is no discharge at the nipples. I would also palpate the breast again with the second, third, and fourth pads of my fingers, just making sure that I didn't feel any masses or anything abnormal there. I would palpate from the clavicle to the bra line, and then mid-sternal to the post-axillary into the axilla, and I would do this in a vertical strip pattern. I would palpate for about 3 minutes, and I would make sure I would ensure that the patient understood how to properly do a breast exam at home. I would want to make sure that she could teach that back to me. I would also, for a male patient, inspect and palpate the breast. Again, here, just looking for any tenderness or enlargement with that, making sure, again, that if it was enlarged, then that could indicate gynecomastia. So for the female genitalia exam, I would have another licensed professional with me. I would have the patient empty their bladder and lie supine in the lithotomy position. I would inspect everything externally, looking at the hair, if there was hair present, looking at the labia, the urethral meatus, and the vaginal opening. Here again, just making note of any discharge, redness, papules, prolapse, swelling, any abnormalities there. With the internal exam, I would select the appropriate size speculum to inspect the cervix. Here just looking to see if there was any cervical displacement or discharge on the pap smear. I would palpate the cervix, and I would palpate the uterus with one hand on the abdomen, and I would also assess the pelvic floor muscles here, just looking at the muscle strength by having the patient bear down for me. So now moving on to the male genitalia exam. Again, I would probably have a licensed professional present with me in the room for this. I would inspect the penis. I would make sure that the skin is nice and intact. I would make sure that if the patient had foreskin, it was retractable. I would also look at the glands, looking for any ulcers or indurations, looking at the glands and the urethral meatus for this. I would make sure on palpation there was no tenderness or discharge. I would also look at the scrotum, just making sure that it is symmetrical. There's no lumps, no bulging masses, no swelling or redness present. I would also just palpate one testy at a time, making sure that it was non-tender, descended, and firm with no masses. I would also test for hernias. I would either have the patient sit or stand for this. I would palpate the bulging in the inguinal or femoral areas. I would have the patient bear down and cough for the femoral area, and then I would have the patient lay down, and if the mass returned, then that would indicate a scrotal hernia. And then for the rectal exam, if this patient were a female, I would have performed this exam while the patient was in the lithotomy position. But since this patient is a male, I would have him lie on his left side. I would inspect the area externally, looking for any cyst, prolapse of the prostate, or the rectum, hemorrhoids, and palpate that anal canal, and test for any tenderness, masses, discharge, any anal fissures or fistulas that could indicate rectal cancer. And then I would have the patient again lie on his left side, flex his knees and hips for the prostate exam, and I would palpate this area by going clockwise and counterclockwise to inspect the posterior surface, making sure that the prostate wasn't boggy, that it felt normal as far as, and that would be rubbery, non-tender, and non-fixated.